We're really fortunate. So he is a pediatrician by training, but he's done so much more. He's an emeritus professor, just recently retired actually at the end of June. So we're sad to see him go, but professor in epidemiology and pediatrics, and he's the past director for the Institute for Global Health Sciences. Specializes in emerging infections, outbreaks, tropical medicine, HIV, measles, tuberculosis, Ebola, influenza, COVID. Did I miss anything?
COVID, of course, yeah.
Toxi.
Oh, some Mpox.
Mpox,
Throw some
yeah.
Mpox in.
Currently working primarily in East Africa, I think.
Yeah.
Yeah.
Yeah. Well, I'm going to Hanoi on Friday.
Oh,
And we're going to try and, they want to try and match the state of sophistication of San Francisco's AIDS control programs in all countries. 100 million people, 10th largest country in the world. I didn't realize that at the time. So, what the hell, you know? And it's top down too, you can imagine. So a lot more top down than anything else we ever deal with.
Really? Oh, man. Well, thank you. Thanks for coming. Give us your lecture today, kind of like the overview of the state of the world in child health.
Well, it's a real pleasure to be here. I've known Teresa on and off since I had brown hair.
I had brown hair too. It's okay.
But when she did a master's degree in global health sciences with us, this was
2014, yeah, 2014.
Yeah, 11 years ago. We'll split the difference. Okay, there we go. Anyway, so I'm a pediatrician. I did residency in peds at San Diego and at Hospital for Sick Children in Toronto. I was an EIS officer at CDC, which is, if you ever want to talk about CDC training programs, I'm one of the few around here that did it. It's very cool, and but it launches you not down a clinical career, it launches you in a kind of a different direction, more of a public health career. But having said that, the other two really prominent people in who are EIS officers here are Art Reingold, who's a professor of epi at Berkeley, and Bonnie Maldonado, who's a professor, who's the chief of pediatric ID at Stanford, but is now, what I find like the great ironies of the universe is it was named the interim chair of the Department of Medicine. You know how they occasionally have internists as chairs of pediatrics? It's the first time there's been a pediatrician chair. That must meant made the other 800 internists feel really good. So I'm going to give you, so there's like a million ways to try and do this. I'm giving you the kind of real basic first layer, which is what do people die of, how many die, where do they die, what's premature mortality, all that kind of stuff. And then, you can obviously drill down on the school performance and, chronic disease risk factors and on and on and on. But let's just get this kind of first level done. So what I wanted to do is kind of big picture stuff and new data from the Global Burden of Disease Study, which is a WHO World Bank study. Child health goals through the Millennium Development Goals, which stopped in 2015. These are UN goals, and Sustainable Development Goals into 2030. Then they asked the question about why has child health improved so dramatically since 1990, and what are the remaining challenges. So Nicholas Kristof, one of my favorite writers at the New York Times, does a piece on global child health at the end of the year every year. And at the end of 2023, he said this was a terrible year, and also maybe one of the best yet, maybe the best one yet for humanity. So what's gone right is that under 5 mortality, this is children who are born live who die before their 5th birthday, fell to 3.6 per 100,000 live births. Anybody want to hazard a guess what under 5 mortality was? I'd say 1820. 20 per 100,000? 50,000 per 100,000.
What?
50%.
50%.
Recording in progress.
Progress. And in cases of poliomyelitis. The year I was born, 1952, there were 52,000 cases of paralytic poliomyelitis in the United States. 12 cases of guinea worm or Dracunculus medinensis, if you like Latin, and trachoma, largely because of the work of the Proctor Foundation, catty-cornered across the street, has almost disappeared. This is the ocular trachoma. There are new vaccines for RSV and malaria. There's actually a new one for dengue as well. All that's really touchy to use. And surprisingly, we've really been able to advance stuff. There's CRISPR technology for sickle cell disease, which I mean, probably you guys deal a hell of a lot more with than malaria vaccine. But it's important to know that we have chronic diseases that we're trying to push through as well. But what's gone wrong is that 3.6 per 100,000 is still almost 5 million deaths among children between 5 and 10 years old in 2022. There are huge conflicts. Gaza, as we hear about every day, but there's renewed genocide in Darfur in the Western Sudan. And there are countries that are getting just hammered by climate change. Bangladesh, which is very low lying and it sort of sits up in a pocket. And so it's prone to cyclones, which are what they call hurricanes in the Indian Ocean. And then Madagascar as well, where there's this kind of boom bust cycle of way too much rain than desert and way too much rain. So it's things are kind of messing around, but overall, close your eyes, close the news off. Wasn't a bad year. This is where the mortality. These are the rates per 100,000 per 1,000 live births per country, and it's you can see that there's a belt here through the Sahel, right? Okay, let's do some geography. Country. Chad.
Mali.
Okay, all right. All right, you're Mauritania, Mali, Burkina Faso, Niger, Nigeria, Chad, okay, Cameroon. But you can see it through this belt in here. Somalia, basket case, DRC, not much better. South Sudan, not much going for it. Central African Republic, not much going for it. But Angola, hugely rich country. Non-stop flight from Houston every day. It's all oil money. It's the most expensive city in the world. Rwanda on the State Department per diem list. So, but these are relatively small countries, with the exception of DRC and Nigeria and Ethiopia. Ethiopia is pretty good. But you get into bigger countries like Pakistan. Pakistan's a huge country, right? And so even, this kind of mortality shows up with a lot of this kind of mortality rate shows up as a lot of deaths. So I think it's always worthwhile to take a step back and say, what's global health? Because people use it very, very differently. And, there are people who are clinicians who think that global health is working at a mission hospital and administering rattlesnake venom and, whatever. And there are those like me who think that global health is working with state ministries of health to manipulate the policy environment and force people to do stuff. But it's kind of somewhere in between, right? It's the Institute of Medicine, which is what we used to call the National Academy of Medicine. Health problems, issues, and concerns that transcend national boundaries and may be addressed by cooperative actions. And this brings us to the World Health Organization's pandemics treaty, which is not yet ratified and not yet finalized and not yet ratified. It's supposed to happen this May, but didn't happen. So slow going, right? And then in the major textbook of global public health, right? The application of the principles of public health to health problems and challenges that transcend national boundaries. Start into the complex array of global and local forces that affect them. Here we are outside the Palais des Nations in Geneva. How many of you have been to Geneva? Yeah? What'd you think of Geneva? Did you go to WHO?
No.
Did you go to the League of Nations building, Palais des Nations?
No.
Well, we cut out the two good things to do at Geneva.
Someone lived there.
Oh, wow.
You were there?
Oh.
Come on, fess up, man. Oh, he lived there, I see. That's got its ups and downsides too. I've spent probably a year of my adult life in and out of Geneva. And, you know, at the end of the day, we always call it, our office, we always call it French Fresno. Somewhat less than charitably. But it's very, there's a lot of stuff that goes on there that's very influential. But the Palais des Nations was the League of Nations building. The League of Nations was the kind of proto-UN that fell apart in World War II. That the US never joined, by the way. But they set this up, the WHO conference up to ratify the WHO Constitution. And then the WHO itself is just up the hill from the Palais des Nations. Who knows where the UN Charter was signed on October 24th, 1945? No. Hey, Teresa, you remember where the UN Charter was signed on October 24th, 1945?
San Francisco.
Which building?
The one where we used to be located.
No, it's the War Memorial Opera House.
Oh,
So San Francisco is supposed to be where the UN was headquartered.
That's cool.
So you can imagine, when you try and park out there in the avenues on Sunday, imagine, 45,000 diplomats with full immunity to just park wherever they want. So, but the Rockefellers wanted to be in New York City and most land at Turtle Bay. True story. So the WHO Constitution, and then our global health class, I make people memorize this. I'm not above making people memorize things. The states parties to this Constitution declare in conformity with the Charter of the United Nations. The following principles are basic to the happiness, harmonious relations, and security of all people. Remember, this is on the back end of 2 world wars. Health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So physical, mental, and social well-being, and not merely the absence of disease or infirmity. The enjoyment of the highest attainable standard of health is one of the fundamental rights of every human being, without distinction of race, religion, political belief, economic, or social condition. The health of all peoples is fundamental to the attainment of peace and security, and is dependent on the fullest cooperation of individuals, states, and the achievement of any state in the promotion and protection of health is of value to all. Some of the very early work of the League of Nations, there was something called the International Health Office that was based in Paris. Was about combating typhus in the Soviet Union, which was a big deal, and it could easily spread across a lot of that, the sort of post-Ottoman world. So they took this stuff very seriously. So this is the World Health Report's the annual report of WHO, and I thought this one kind of captured some of the stuff pretty well. Some of the major challenges: a reduction in the burden of excess mortality and morbidity among the poor, focusing more on interventions that can achieve the greatest health gain possible within prevailing resource limits. So don't go out and reinvent the wheel where we got lots of good wheels sitting around. Countering potential threats to health resulting from economic crises, unhealthy environments, risk behaviors, development of more effective health systems that can improve health status, reduce inequities, enhance responsiveness to legitimate expectations, and increase efficacy. So in the U.S. policy language, that's called health system strengthening. And now this has been added as a pillar of WHO universal health care. And to make the investments in research and development. They're directed towards diseases that overwhelmingly affect the poor. This is the so-called 10-90 gap. 90% of the research goes for diseases that affect 10% of the population. So this is my list. So some of the big meta trends in global health are the globalized economy and widening income inequities. What do you think the median age of the world's population is? Well, let's ask it differently. Who in this room is closest to that median age? It's probably about 17.
Oh.
Yeah, so yeah. Before you start patting yourselves on the back too much. And we see this huge spread in income, right? Armed conflict, Gaza is a classic example. And also Ukraine, climate change, population growth with progressively younger populations, migration and urbanization, and then the continued emergence of zoonotic diseases, which is a function of population density. We push back into places where people haven't lived before. That's where you run across this stuff. So I did this on Monday night or Monday morning. Current population, 8 billion people. There have been 81 million births and 38 million deaths. And the so-called national increase, which is this complicated mathematical thing called subtraction. It's about 43 million people as of 2/3 of the way through the year. Most populous countries, you can see India is about to surpass China. China's done a pretty good job of keeping the lid on population growth. India less so. US, Indonesia, Pakistan, Nigeria, Brazil, Bangladesh. Russia is the only one whose population has fallen on this list. And that's not because of people splitting off, that's just Russia. And then Mexico's 10th. So you get an idea of how how the population has grown steadily. Okay. And if you ever come and take our course, you'll learn all about Malthusian catastrophes, carrying capacity, and astral projection, and all this stuff. So this is the world population from the year 200. You're not going to see a lot of slides in the Department of Pediatrics where the year 200 is listed to 2100. And you can see it really took off with the start of the Industrial Revolution in 1700. And then population growth is only since 1950. This is the kind of the second derivative term as pretty much been on a downward trend, trying to get to 0. Okay, so what are the trends in child mortality? This is, I'm sorry, I was making stuff up. So it's 43.3% in 1800. And this is the proportion surviving for the first 5 years of life. And I put all the references down here in the bottom in case you ever want to use these slides, which is a problem with using slides like this. They have to be updated all the time. If you look at deaths by age group over time, so you have under 5 and under 1. Okay, so under 1 mortality, which is called neonatal mortality or infant mortality. Well, they're slightly different. Neonatal mortality includes stillbirths, but infant mortality doesn't. But anyway, WHO, this is how UNICEF was reporting them out. So under 5 mortality is per live birth. That's fallen over time, and now it's around, as I said, 3.9 per, well, it's whatever, however it works out. This is 39 per 1,000. And at least half of that is infant mortality, right? So if you look at down here at the far right-hand side of the left-hand graph, at least infant mortality represents half of that. Okay. And then if you look at the total number of deaths, very similar sort of thing. Very steep downward trend in under 5 deaths and less steep, but nonetheless significantly downward trending in neonatal deaths. Now, this is just a different way to look at this. And if you go to these websites, you can play with this stuff. And this is how how the World Bank divides the world's population by country. High income, upper middle income countries, a country like, say, Croatia. A lower middle income would be Dominican Republic, Peru, something like that. And then low income is Bolivia or Paraguay. And some of the really poor African countries. What you can see as you move farther out towards as the rates go up. So this is child mortality going from left to right. The farther you go out, the greater these preponderance of these low income dots are. The big yellow one, what do you think that is? That's the second to the end. Do you know what I'm talking about? This one here?
Mm-hmm.
What do you think that is? The size of the circle is not population, by the way. Yes, that's the second largest circle. I think that's to give you a hint. India. Right. And this is probably Pakistan here. And this is China, right? So China's doing pretty well. Okay. So where was under 5 mortality the highest? I showed you this before. Again, predominantly in Central African regions. This is Haiti over here, which is just flip up. And then also in the stands. Now, what do children under 5 die from? This is an interesting group called the Institute for Health Metrics and Evaluation at the University of Washington, and they do all these graphics. So this is under 5 mortality, both sexes, in 2021. And so it's divided into three, don't pay attention to other COVID stuff out there. It's divided into 3 groups. The red-ish colors are the neonatal obstetrical and infectious and nutritional diseases, right? That's kind of what we work on in IGHS. The blue are chronic diseases, right? And the green are injuries, external injuries. So road traffic accidents, drownings, falls, that sort of stuff. So what's the leading cause of mortality for children under 5? And neonatal complications, so births, like that, right? Lower respiratory infections, malaria, congenital defects too. Birth defects are a big thing, and in the U.S., the 3 leading causes of death for infants have been for a long time were I said neonatal. Neonatal is the first 28 days. I'm sorry, I made this. Bad obstetrical outcomes, right? Congenital defects, and then sudden infant death syndrome, which doesn't show up here yet because it's probably washed out with something else. It's probably called pertussis. But also look at these injuries too, right? This is sort of an increasing focus of WHO, and we have a group at Ortho that's very interested in this. Do you deal with them very much? Right?
Yeah, like
SCOT or whatever they're called.
Chessa.
I got.
Oh, I got and what's his name? Dave Shear. No, but
Problem is you don't need orthopedic surgeons, you need traffic engineers. stay at 9. But then if you look at 15 to 14, 5 to 14-year-old, there are many fewer deaths in this group. Oh, the density of this is is how much it's changed. Okay. So, where it's really dark, it means it's been a really good change. It's come down a lot. Okay.
What's INTS?
And I knew somebody was going to say that. I just sing it. I was saying, I wonder what INTS is.
Typhoid, isn't it?
Non-typhoid salmonella.
Okay.
Just made that up. But you can see, forget that. We see malaria, lower respiratory infections, meningitis, encephalitis, measles. Measles, big deal. Nasty disease. But then you also get over here and you start getting some chronic disease here. Some of them are malignancies, congenital defects still. Right? Epilepsy. Right? And then big thing is this whole trauma. Now, if you can pick this out, if you go to this website, which I listed on the prior slide, you can pick it out by country. So you can pick out Syria or something. This thing about conflict and terror is just huge. Right? Okay. Now, if you look at causes of death in children, this is slides from a big Lancet review in 2017, so it's slightly out of date. But you can see pretty much everything is falling, which is good. Now, some things like, drowning, cancers, those sorts of things are really hard. It's harder to get a handle on. The cancers we can vaccinate against don't show up in adolescence. They show up in young adulthood and middle adulthood, like hepatomas and
Cervical cancer.
yeah, cervical, yeah. But but look at all this stuff, right? They say, why are you interested in infectious diseases? Infectious disease, infectious disease, infectious disease. Congenital birth defects also includes congenital syphilis, by the way. Infectious diseases, that sort of stuff, right? So this is still, these category 1 diseases are still a huge big deal. Now, will they remain that way forever? No. Are they that way in the developed world? No. But if you look at overall, and for the places we work, these still are major causes of mortality. Sorry. Now, having sung the praises of infectious diseases, I'll toss you a bone here about non-communicable diseases. So we talk about NCDs and NTDs, just to confuse everybody. NCDs are non-communicable diseases. Neurological disease, diabetes, renal disease, neoplasms, cardiovascular disease, digestive disease, respiratory disease. And these are in kids less than 5. Right? So the respiratory disease is that kills children less than 5. Teresa, what do you think that is?
RSV.
RSV, I had some asthma maybe too. Remember, this is not Nickety Wilson's. Do you even have that anymore? You know what that is? It's from hyperventilating.
Oh.
It's like, it's like by a Stevie Wonder blind. Know that?
Oh, from oxygen surgery.
Yeah, he had retromental fibroplasia. Not to talk about individual patients. So a lot of this is congenital, like heart disease and stuff. All right, so how does poverty fit into mortality patterns? All right, so poverty and its consequences, which are things like nutrition, sanitation, are major factors in reducing healthy life in the world. And it doesn't just pick off the kids, it picks off the parents too. It forces city dwellers in resource-poor countries to live in overcrowded and unhygienic conditions. the lack of water and sanitation provides breeding ground for infectious disease and the development of drug resistance. And then poverty correlates with rapid population growth. That's tremendous. Affects the health of women. How many of you been in a rural African slum or a Brazilian slum, like Cabera or someplace? Where have you been?
Yeah, and I really.
Yeah, Cabera, yeah. But yeah.
I've been to favelas in by Rio and then also
Oh, and
in South Africa.
are you Brazilian?
and Peru.
Peruvian. I was gonna practice my Portuguese. Where you were in Cabera? You must have been on Cabera. Yeah, yeah. The ones in South Africa aren't that slummy. You know, when you look at the ones in like Brazil and stuff, I mean,
I don't know. The townships are really.
yeah. So why does this happen? Well, you know, the greatest risk factor for infant mortality is maternal undereducation. Right? There's limited funding for health. The access to healthcare and the kind of healthcare you can access are limited. There's overcrowding with poor sanitation in the slums. Rapid child growth means close child spacing. Okay. And there is a surfeit of women. There's an excess of women who want to use modern contraceptive methods, but who are not able to access them. And if you do our course, we spend a whole week talking about this stuff. So, did any of you go to Stanford? So I went to Stanford. My undergraduate advisor was a chemistry major. I was one of the things I majored in was chemistry. And people say to you know, who's the most influential person you ever met? Right? I met presidents and stuff. Yes. But this guy is a guy named Carl Jurassic. You know who he is? He was a steroid chemist. He invented the birth control pill.
Oh,
Talk about something that shook the world.
wow.
You know, there was 1964, then there was 1966. And it was just. I had sisters that age. I see this firsthand. Lack of affordable and available health technology, high maternal mortality. So it's still 500 per 100,000 in the developing world, 100,000 live births. And then 7 per 100, it's not live births, 500 per 100,000 pregnancies. And then 7 per 100,000 in high income countries. And when we see mothers die here, they got like many things going on, right? They got amniotic fluid emboli, they have underlying disease. What you must see them in the ICUs occasionally.
Not on our side, but yeah, like COVID or respiratory infections. But we still have health disparities in maternal.
Oh, I'm sure you do. I'm sure you do. What is it in African American women in California? It's like,
I don't know.
it's like 20. So maybe
Yeah,
it's like 3
definitely.
times as high. So, yeah, let me see if I can do this. This is the coolest thing going.
Oh.
Don't worry, that's not that you're not.
We get it.
Is something as a visual aid to envision the influence of health and wealth. So you have life expectancy. So this is very crude stuff, okay? Life expectancy in years here on the y-axis at GDP per capita. Now this is what it looks like in 2022. The size of the colors refer to continents, geographical areas. And the size refers to countries. So here's US, way out here, Luxembourg, where I want to be. Okay, so we're gonna roll this back. 1800. You can follow it forward over time. And so here's China, and here's India, right?
Mhm.
You can see these hits that were taken. That, for that yellow drop there, that was the US Civil War.
Mhm.
And you can see, well, you'll see World War I and the Spanish flu here in a second.
Whoa.
Curtsy.
Jesus.
And now that these drops, that the
Yeah,
earlier
that's
drop in the
the one,
thirties
yeah.
was the Ukrainian starvation.
Oh.
Now watch what happens with China.
Yeah,
Just watch what happens.
Oh. There she goes. Or-
Isn't that cool?
Yeah, very.
Yeah.
Yeah,
Whale watching, is that what you said?
We were saying the curtsy was like a little, drop your stomach a little bit.
Yeah.
Yeah, yeah. Okay, anyway, this is one of what's called Gapminder. And there's a kind of placeholder in the slide set. Oop, there you are. I remember one of them. Start reciting Dr. Seuss.
Really?
So Conrad Cornelius. You gotta have a little, you gotta have a little count to 5. And this is just another example. This is a log table, so 1%, 10%. And you get the idea that these countries out here with a portion of the population in extreme poverty do much less well with child mortality. Now, some of the goals for child health is we have the Millennium Development Goals, which were formulated in 2000, signed, they were to run through 2015, and they had 18 target goals and 19 targets. We were lucky there were like 5 of these goals were about health, but reduced child mortality was one of them. And the overall goal was to reduce child mortality, under 5 mortality, by 2/3 between 1990 and 2015. And it fell from 90 to 43. So it was almost a 52% reduction. For different parts of this, there was measles vaccine coverage and stuff like that. But it's that was one of the great, huge successes of the Millennium Development Goals. So why did it decrease? Well, there's better maternal care, right? You got to start at the beginning. Contraception with better child spacing, better infant care. This is exclusive breastfeeding for 6 months. Neonatal resuscitation, big deal that is not widely practiced in some parts of the world, like Pakistan. Increasing levels of maternal education, immunizations, including manure vaccines, malaria bed nets or insecticide-treated malaria bed nets, and then improved care. And there's this thing called the Integrated Management of Childhood Illnesses, which is put out by WHO, and is an evidence-based thing, a sort of syndromic approach to treatment. So oral rehydration solution was one of the things that flowed out of that. But my wife was the head of the ER at Oakland Children's for 30 years, 35 years. And I got these IMCI books for every so the residents are going to look it up, how they're supposed to do it. So just so you know, you're up to the international standards. Just because the academy says to do something doesn't mean that's right. Now, the Sustainable Development Goals are much more, are much broader, and there's only one that's about health, which is number 3, good health and well-being. Although 0 hunger, you can say, okay. These are in place till 2030, and have been around since 2015. So there are two that are kind of touch on what we're talking about today. Reduce global mortality ratio to less than 70 per 100,000 live births. Currently worldwide, it's at 216, so it has to come down by 2/3. By 2030, end preventable deaths of newborns and children under 5 years of age, with all countries aiming to reduce neonatal first 28 days mortality to as low as 12 per 100 per 1,000 live births, and under 5 mortality to at least as low as 25 per 1,000 live births, right? And we're currently at 39, so that needs to fall by 36%. Okay. So this is how this stuff gets diced up and sort of thought through at the highest levels. All right, so there's a kind of interesting question in all of this. Is if child are surviving better, what does that do to the total fertility rate? Are people going to have more kids because they can, because they're going to survive, or are they going to have fewer kids? So there are two important factors associated with total fertility rates. So empowerment of women in society and relationships through education, labor force, participation, and strength of rights, and the increased well-being and status of children. So child mortality, you can see here, this is top one, fertility rate by child mortality. So you can see there's this pretty straight line association. The lower the child mortality, the lower the fertility rate. Okay. And this is average number of children versus child mortality. That's it.
Fertility's on the y-axis for both.
Yeah. Anyway, so the fewer kids,
Yeah.
lower the fertility rate. So some of the remaining challenges in infant and child health are survival out of the neonatal period, which are better obstetrical care, higher educational attainment for moms, kangaroo mother care. Do you guys know about that?
Mm-hmm.
They do it here.
Yeah.
Finishing the job with communicable diseases, antiretroviral therapy, meningococcal. The interesting thing about ART is that a lot of kids got put on ART or dolutegravir came around, and they're on pretty ineffective regimens unless they've been switched out.
Mm-hmm.
And so there's a big kind of move in Africa where most of the pediatric HIV is to get kids switched out and on dolutegravir because it does a much better job and it's much more durable protection. Meningococcal rotavirus vaccines, measles vaccine catch up because of the COVID was a huge big deal. We're probably 100,000 doses behind. We have bed nets, which have been around for a long time. We are actually involved in one of the original evaluations of bed nets, which was when Rotary of New Zealand gave Vanuatu. Vanuatu is this country off the coast of Australia, kind of like New Caledonia. North Island, 12 miles, Gap, South Island, too far for a mosquito to fly. And they gave them the big fundraiser for insecticide-treated bed nets. It only had half as many as they needed. So only the North Island got them. So that was the evaluation, right? One of the experiments of nature. Cool. IRB wouldn't have liked it, but that's the way it went down, right? And we now have malaria vaccine, hugely expensive, kind of complicated to use, but it's a common thing. Improved nutrition, paying attention to chronic disease prevention, especially in middle income countries. Road traffic accidents, survivability. If they're not going to survive with road traffic accidents, there's not much you can do about it, right? Just try to avoid them altogether. But there's often a kind of a middle position taken to try and scoop them and get them to a place where they can get some level of care, or to teach people around them how to do better care. So the taxi drivers are really good source of stuff. EMT ones. Limiting other trauma poisonings, poisoning meaning environmental poisonings, and war, and decreasing the proportion of the world's population living in poverty. I'm sorry, I've been sick. My voice is kind of in and out, as you can tell, but happy to answer any questions. Bruce, may I add anything? Anyone anything?
I can add it as a comment and a question, which is, you mentioned a lot of the interventions, the payment of those, how we pay for those interventions and the investment in the Millennium Development Goals.
Yeah.
Do you think it closely follows the dollar line? Like we see a surge in money, we see a surge in, or a decrease in infant mortality?
I mean, for certain pricey things, yes, right. Don't forget that, what are we trying to do? When we say, better birth outcomes, probably talking mostly about obstetrical hemorrhage. And you remember Sloan, was she around the other day? I was in the nursing school as part of IGHS, who had basically retrofitted or repurposed mask trousers. You guys know what mask trousers are? Military anti-shock trousers. They're what they put on the jet fighter pilots. So they go through these high-speed turns, they blow the bladders up so that, if you're a jet fighter pilot, the only thing that's important is the distance from your aortic valve to your retina. Okay, that's it. If it starts to go like that, wow, you're toast, right? So they got to teach them about. So that's why they all look like Turkish weightlifters. They're about 5'6" and 200 pounds, right? All muscly. They're the ones who can take those high-speed U-turns, right? But they have these pants that blow up bladders in the back and in the legs and in the torso and stuff. And so we use them. We have used them on ambulance rigs for hemorrhage, on the scene hemorrhage. But so I only got the idea that you could kind of figure out where the uterine artery was and stuff. So you don't want to include that probably. That you could, well, you probably do at this point in time. You could use them for obstetrical hemorrhage and get some longer transport to places where you do definitive procedures like C-sections or hysterectomies. So that's that's one of the kind of swords into plowshares stories. What else do we have? What are other big things?
I was gonna ask
I
you.
mean, neonatal resuscitation is pretty straightforward.
Helping babies breathe.
Sorry.
Helping babies breathe. Kind of a simplified NRMT. Rebel, where do you think, what do you anticipate the challenges will be in global child health in the next couple of decades?
I think it kind of depends on the sort of the big infectious disease trends. We got lots of vaccines. So there's a whole UN agency that's sort of semi-UN agency that's devoted to vaccine distribution called Gavi. It used to be called the Global Alliance for Vaccines and Immunobiologics. Now it's called Gavi. GAVI. And they take money from governments and also do things like advanced purchase things. So if you develop a vaccine for this, we guarantee we'll buy the first 100,000 doses. I think those are called advanced purchase commitments. I think they kind of have the vaccine stuff, in hand, but it's all kind of push-pull stuff. So, what's going to come to California? What are we going to worry about coming to California? Well, I think dengue will be in California, and especially Southern California, coastal California. It's not going to be here. It's too cold. Nothing will grow here. Not even artichokes. But it's one of those. It's just one of these kind of things that you feel coming and coming and coming and coming. And the dengue vaccines are really complicated to use. You got to make sure that they've been previously infected and blah blah blah. But so I think the vaccine stuff is kind of there, right? I think obviously, so much of neonatal survival is about obstetrical care. You know, getting people trained in real obstetrics, getting surgeons cross-trained in obstetrics, getting clinical officers cross-trained in C-sections. So there's this 2-year kind of PA sort of program in a lot of East African countries. I think that those are big important things, you know, and then kind of, you know, Futurama stuff. You know, what are we going to do about chronic disease prevention? And you know, is that something that we really can make a dent in? I mean, we haven't made that much of a dent in the US. You know, what would we do? Right? Well, we can screen for certain metabolic diseases. Right? I have a daughter with congenital hypothyroidism who was picked up on day 5. Okay? Now it's a little later, kind of useful. But it's, you know, those things are kind of gimmies. Those are low-hanging fruit, PTs, that sort of stuff. You start talking about CRISPR technology for sickle cell. That's a huge burden of disease, massive burden of disease. But I think it's something that's really worthwhile focusing on. And then you get to all the mental health stuff. Right? What are you going to do about all that? I'm chairing a committee for a National Academy about autism and military's program for dependence, for treating autistic dependence. Adequate or inadequate, or why would you do this or that, you know, and all this stuff. I have absolutely no idea what we're talking about. But it's, you know, the whole mental health stuff, the whole mental health aspects of child health, you know, they don't really scratch the surface of this stuff. There is a woman at who's in our psychiatry department named Susan Efforts, who does a lot of kind of big psychiatry stuff, like, you know, teaching people to do lay psychotherapy for post-traumatic stress disorder. Right? And, you know, but that's what you're talking about. You're talking about big multipliers like that. And it's, you know, nobody's going to be doing drugs, right? So none of that's going to involve drugs. None of that's going to make a dent in schizophrenia. You know, it's really about acquired affective disorders. And then, you know, the road traffic things are, you know, for those of you who've driven around Africa, how do you? You've been around Africa? Yeah. Wear your seatbelt? Yeah. Good. No.
So a lot of the cars don't have seatbelts.
Yeah, we'll get one that does. I mean, that's the sort of stuff. It's like, duh, but it's, you know, but they don't work and this and that, and, you know, you got to make the effort, right? So that's my one. I got lots of safety tips for traveling in other parts of the world. One is always wear your seatbelt.
And helmets.
Oh, you don't have to wear a helmet inside the car.
Just on bikes and boaters.
Yeah, boaters.
We have a question for you in the chat. Interested in hearing your thoughts on the synergy between evolving global child health conditions and global healthy aging development. So how do you see global healthy aging and global child health support or challenge each other on the policy and international level, especially given the shifting demographic structures across continents and populations?
Wow.
Can you answer that in one sentence?
Yeah, I've never really thought of it that way. It's it's like, you know, there's why do we have all these programs for the elderly? It's because the elderly vote, right? And, you know, you see a lot of 5-year-olds voting, well, maybe in the little elementary school things. But no, it's just, it's, you know, somebody's got to be an adult in the room and make decisions that allocate resources in a kind of equitable fashion. And if you're interested in, you know, kind of the Bhutanese happiness index sort of thing. You want a long life and things like that. If you're interested more in a gene pool and genetic diversity, you want the investment on the front end. It was very kind of Machiavellian, not eugenic. I found out that what was that guy's name at Stanford in the 30s? 10. He changed the name of the junior high school because he was a eugenicist.
No, that's the full name.
Sorry.
Any other questions?
Well, how much have you guys traveled?
That's our.
You
map.
in California?
Yeah, that's our. map.
Oh, really?
Specifically.
I was in Sri Lanka.
Mhm.
What's it between China and Taiwan? Is that
It
those
was-
islands that
it's a
they're
little
being shelled all the
abstract,
time?
Thank you very much, George. Really appreciate your time coming all the way across the bay. Enjoying
Well, I thought this was gonna be head and shoulders. I said,
It
yes.
was supposed to be, I know, it failed to secure a room. Yeah.
Well, got me out of the